So, a patient walks into the emergency room, right? They're gripping their chest, they're sweating, and obviously struggling to breathe.
Yeah, the absolute classic presentation.
Right. And for, decades, the almost instinctual reflex for a doctor in that scenario is to just administer nitroglycerin. Open up the blood vessels, get the blood flowing back to the heart.
Exactly. It's practically muscle memory at this point.
But what if I told you that if this patient is having a very specific type of heart attack, a right ventricular infarct, giving them that standard dose of nitroglycerin, could actually cause their entire circulatory system to just instantly and catastrophically
It
collapse?
sounds totally counterintuitive, but yeah, it's a terrifyingly real scenario.
And today, we're going to find out exactly why that happens. So welcome to the deep dive. We are taking a really intensive, high-yield clinical journey through the human body today, pulling the absolute best insights from the gold standard text, Step Up to Medicine, 5th edition.
Yeah, and whether you're, prepping for board exams, or you're a young professional out on the wards, or even just a self-taught learner who's fascinated by how your biology actually works, our goal is to really cut through the noise here.
Right. We want to master the essentials of internal medicine. So we're building a logical framework from the ground up, right?
Exactly.
Yeah.
Instead of just memorizing lists of symptoms, we really want to focus on the whys and the hows across the major organ systems. Because modern medicine, it really isn't about isolated facts. It's about recognizing the cascading, interconnected systems of the body.
Totally. And we are starting at the very center of that system today, which is cardiovascular emergencies.
The pump.
The pump, right. So when a patient comes in with chest pain, the stakes are obviously incredibly high. How do clinicians even begin to sort through what might just be like heartburn versus something that's actively trying to kill you?
Well, you start by aggressively ruling out the immediate life threats. I mean, in clinical medicine, we always fall back on the ABCs: airway, breathing, circulation.
Right, the basics.
Exactly.
Yeah.
Because the heart drives the entire circulatory system. Any complaint of chest pain is the ultimate red flag. So the immediate threats you have to look for are acute coronary syndrome, or ACS, an aortic dissection where the main vessel actually tears.
Which is incredibly dangerous.
Oh, incredibly. And then there's a pulmonary embolus, or the tension pneumothorax, where air gets trapped in the chest and literally crushes the heart.
Wow. Okay, so how do you catch those?
So the baseline diagnostics have to include an ECG to look at the electrical rhythm, a chest X-ray, and of course, cardiac enzymes.
Okay, let's talk about those enzymes for a second, because I feel like I hear the term troponin thrown around on medical dramas all the time. Like, what is actually happening at a cellular level that makes troponin such a huge red flag?
Yeah, that's a great question. It really comes down to cell death. When the heart muscle is starved of oxygen, which is a state we call ischemia, the cells begin to die, and their membranes actually break open. Yeah, and when they burst, they leak their internal proteins directly into the bloodstream. So troponin and another enzyme called CKMB, they're structural proteins that are highly specific to heart muscle.
Oh, so they shouldn't even be in the blood normally.
Right, exactly. So if we draw a patient's blood and we detect high levels of troponin, it is definitive proof that myocardial cells are actively bursting and dying.
Okay, that makes the distinction between stable angina and a full-blown heart attack make a lot more sense.
Yeah, absolutely.
Because, like, if someone has stable angina, they might feel substernal pressure when they jog, but it goes away when they rest or take nitroglycerin, right? Usually in under 15 minutes. So the tissue is stressed, but it's not dying.
Exactly. But if that pain lasts more than 30 minutes and, the patient is profusely sweating, that is an acute myocardial infarction. The oxygen demand has critically outpaced the supply, and the tissue is infarcting. It's dying.
Right.
Now, to evaluate a patient who only has that stable angina, we use a stress test. We push the heart's oxygen demand by having the patient exercise, and then we just watch for changes.
And what makes a stress test positive?
We consider it positive for severe disease if their blood pressure drops, or they develop significant arrhythmias, or their ECG shows specific downward shifts. We call those ST segment depressions.
It's basically exactly like testing a car engine.
Yeah, that's a good way to look at it.
Right. Like if you have a partially clogged fuel line, letting the car idle in the driveway might look completely fine. But the moment you merge onto a highway and floor the gas pedal, which is the stress test, the engine starts to sputter, you're forcing the system to reveal its hidden limits.
Exactly. And we can actually visualize that stutter using myocardial perfusion imaging.
How does that work?
So during the stress test, we inject a safe radioisotope, usually like thallium-201, into the blood. Healthy, viable heart cells will actively extract that thallium from the bloodstream. So when we scan the heart, any areas that do not light up what we call cold spots indicate dead zones where blood flow is completely blocked.
Man, that's fascinating. Which I guess brings us back to the scenario from the very beginning of our discussion, the right ventricular infarct.
Ah,
You
yes.
mentioned earlier that giving nitroglycerin to someone having a heart attack opens up the vessels. So why does doing that in this specific instance cause the patient's blood pressure to just crater?
Well, it's a really fascinating problem of hemodynamics. The right ventricle is the chamber that pumps blood into the lungs. So when it suffers an infarct, the muscle becomes incredibly weak and flabby.
Like it just loses its tone.
Right, it can no longer squeeze effectively. So instead, it relies entirely on the passive pressure of the blood returning from the veins to essentially push blood through that broken right ventricle into the lungs and over to the left side of the heart.
Gotcha.
And we call that return pressure the preload.
Okay, so the incoming blood acts almost like a ram, just forcing the system forward because the pump itself is completely broken.
Precisely. Now, nitroglycerin is a super potent vasodilator, particularly on the venous side.
Oh.
Yeah. If you give it, all the veins in the body suddenly relax and expand. The blood just pools in the legs and abdomen, and the preload drops to near zero.
Wow. So without that incoming pressure, the weak right ventricle just stops moving blood forward altogether.
Exactly. The left side of the heart suddenly has nothing to pump, and the patient's systemic blood pressure completely collapses.
Because you're actively removing the only thing keeping the engine turning over. That is terrifying, but mechanically, it's brilliant.
It really is.
And just before we leave the heart entirely, the text mentions something called Dressler syndrome that happens like weeks after a heart attack.
Yeah, so Dressler syndrome is an immunologically based complication. Basically, when a heart attack kills cardiac tissue, the immune system eventually arrives to clean up the necrotic debris.
Makes sense.
But in some patients, the immune system actually gets confused and mounts an inflammatory attack against the heart's lining. This causes pericarditis and pleuritis weeks or even months later.
That's wild. How do you even treat that?
Interestingly enough, the treatment is simply high-dose aspirin to just calm that localized inflammation down.
Huh. Okay, well, if the pump itself is working, the next logical vulnerability has to be the plumbing attached to it.
Right. A leak in the vascular system leads to what we call hypovolemic shock.
Exactly. And shock simply means the tissues aren't getting enough perfusion. When you spring a leak and lose blood volume, your preload drops, which means your cardiac output drops.
And the body just panics.
Oh, totally. It recognizes the pressure is falling, so it triggers a massive compensatory response. It clamps down on the peripheral blood vessels, drastically increasing systemic vascular resistance, or SVR, to try and maintain blood pressure to the brain and the heart.
I always wondered about the breaking point there. You know, when someone is actively bleeding, at what exact tipping point does the body's natural defense mechanism just kind of throw its hands up and fail? Well, the clinical tipping point generally happens when you lose about 20 to 25% of your total blood volume. We actually categorize hemorrhage into classes based on how the body reacts.
Oh, okay. Let's unpack that.
So, if you lose up to 15%, which is class 1, you barely notice. Class 2 hemorrhage is a 20 to 30% loss. At this point, the body is clamping down hard, and the heart has to beat much faster to circulate what little blood is left.
So that's why the primary sign here is a racing pulse, right?
Right.
Usually over 100 beats per minute.
Exactly. But class 3, which is a 30 to 40% loss, that's where the dam really breaks. The vasoconstriction just can't keep up anymore.
So the blood pressure just tanks.
Yep, the blood pressure suddenly drops, oxygen stops reaching the brain, and the patient becomes severely confused. And then by class 4, which is over 40% volume loss, the plumbing is practically dry.
Wow.
The patient falls into a coma, and the kidneys completely stop making urine just to save every last drop of water.
That is brutal. I mean, leaks are devastating, but blockages can be just as fast, right? The text differentiates between arterial starvation and venous drainage problems.
Yes, it's an important distinction.
Because if someone has chronic venous insufficiency, their veins just struggle to drain blood back to the heart. So their legs ache. But if they prop their feet up, gravity helps the blood drain and the pain goes away.
Right. But an arterial blockage is the complete opposite. Peripheral arterial disease causes pain when walking, because the muscles aren't getting enough fresh oxygenated blood.
Oh, I see.
So if they elevate their leg, they're forcing the blood to fight gravity, gives us to get past a blockage,
Yep.
which makes the pain significantly worse.
Okay, and the most extreme version of that is acute arterial occlusion, right? This is the classic 6Ps. Pain, pallor, polar meaning the limb turns ice cold, paralysis, paresthesias, and pulselessness.
Exactly.
It's literally like a house abruptly losing its power, its heating, and its communication lines all at the exact same time. The tissue is completely isolated and just freezing to death in real time.
That's a great analogy.
Hmm.
And, we see massive blockages on the venous side as well, which often travel back up to the lungs, a pulmonary embolism or PE.
Right.
The mechanism here relies on Virchow's triad. You need sluggish blood flow, injury to the blood vessel wall, or a blood chemistry that makes it hypercoagulable.
Oh, so that's why the risk factors include things like prolonged immobility or major surgeries or underlying malignancies.
Right. Even estrogen therapy, which literally makes the blood thicker.
Now, if a clinician suspects a PE, the sources highlight two landmark studies that really dictate how we hunt for that clot: the PIOPED study and the Christopher study. What do those actually tell us to do?
So the PIOPED study established the criteria for using ventilation perfusion scans, or VQ scans.
Okay.
A VQ scan looks at the air getting into the lungs versus the blood flowing past them. If a segment of the lung is getting plenty of inhaled air but zero blood flow, you have a massive mismatch, and that points to a clot.
That makes sense. And the Christopher study.
The Christopher study validated the use of spiral CT scans. So instead of just looking at the flow mismatch, a spiral CT lets us literally see the physical clot sitting inside the pulmonary artery.
Oh, wow. And if we find a clot, we usually use blood thinners. But what if a patient has, like, a massive stomach ulcer and is actively bleeding? We obviously can't give them anticoagulants.
Right, that's a huge contraindication. In that case, clinicians place a tiny metal umbrella called a vena cava filter into the main abdominal vein to physically catch any more clots before they can reach the heart.
That is amazing. So when systemic pressure drops from shock or when massive clots disrupt the flow, the organs that require the most constant high-pressure blood supply are obviously the first to suffer.
Exactly. The body's biological filters the kidneys, and the liver they begin to shut down.
So let's focus on the kidneys. Acute kidney injury, or AKI, is incredibly common in sick patients. But the text really emphasizes that diagnosing an AKI is a careful, stepwise process of elimination. You can't just assume the kidney itself is broken right off the bat.
No, you really have to rule out external factors first. We check for postrenal causes, which are physical roadblocks like kidney stones, or maybe an enlarged prostate blocking the urine from getting out.
Okay. And if it isn't blocked?
Then we check for prerenal causes. Prerenal just means the blood flow arriving at the kidney is severely diminished, usually from dehydration or shock.
And this is where we run into a really heavy clinical metric called the fractional excretion of sodium, or FeNA.
Yes, FeNA is crucial.
Because our sources state that if a patient's FeNA is less than 1%, they're in prerenal failure. But if it's over 2 or 3%, they have intrinsic failure, meaning the actual kidney tissue is damaged. So how does measuring sodium in the urine tell us the structural health of the kidney?
It's actually a brilliant physiological test. FeNA simply measures how much sodium the kidney filters out into the urine versus how much it pulls back into the blood. When your body is severely dehydrated, which is a prerenal state, the kidney senses the low blood pressure. Its natural survival mechanism is to fiercely hold on to salt and water to try and plump up the blood volume.
Ah.
So a FeNA of less than 1% means there is almost zero sodium in the urine. That proves the internal machinery of the kidney is working perfectly. It's just desperately trying to save your blood pressure.
Wow, so the kidney is acting like a frantic accountant, just holding on to every single penny of sodium it can possibly find.
Exactly. But if the low blood pressure lasts too long, the kidney cells suffocate and die. This is called acute tubular necrosis, which is the most common intrinsic failure.
And that's where things get bad.
Very bad. The dead cells actually slough off into the urine, which we see under a microscope, as muddy brown casts. Because those cells are dead, they can't do their job of reabsorbing sodium.
Oh, so the salt just spills out.
Right. The salt simply spills out into the urine, pushing the FeNA metric over 2 or 3%. The accountant is dead, and the vault is basically wide open.
That brings tremendous clarity to a metric that, honestly, usually just gets memorized. And speaking of the urinary tract, we have to mention kidney stones. Finding blood in the urine, hematuria, often points to a stone.
It does.
But the critical pearl here is that if you find hematuria paired with pyuria, which is white blood cells in the urine, that is an absolute clinical emergency.
Yes, because white blood cells indicate infection. A stone causing a blockage is painful, obviously,
Hmm.
but a stone causing a blockage with an infection trap behind it means bacteria are multiplying rapidly in a high-pressure stagnant pool.
And the kidneys filter so much blood.
Exactly. Because the kidney filters so much blood that trapped infection will rapidly cross into the bloodstream and cause fatal sepsis.
Scary stuff. And the liver, our other major factory, is just as vulnerable, right? Acute liver failure is a drastic diagnosis. It requires an acute injury occurring over less than 26 weeks, accompanied by severe confusion and encephalopathy and a failure of the liver's synthetic functions, like making blood clotting proteins.
Right, but the catch is the patient must not have any prior underlying cirrhosis. It has to be a previously healthy liver that just suddenly crashes.
Wow.
And right next door, the biliary tract, the tubes draining bile from the liver, can experience its own high-pressure infections. This starts as cholangitis.
Which has a classic presentation, right?
Yes, Charcot's triad, a fever, pain in the upper right abdomen, and jaundice because the bile is backing up.
And if that blockage isn't cleared, it progresses to Reynolds pentad. That adds altered mental status and septic shock to the triad.
It's highly toxic. The backed up, infected bile is incredibly toxic, and without emergency surgery to decompress the plumbing, it is rapidly fatal.
So while we are looking at the abdomen, there are two really quick gastrointestinal mechanisms we need to highlight. First, if a patient has a cecal volvulus, which is where the bowel twists on itself and cuts off its own blood supply, attempting a barium enema to see the blockage is strictly forbidden.
Oh, absolutely.
Huh?
Because the bowel wall is actively dying from a lack of blood, making it paper thin.
Right.
Pumping high-pressure barium fluid into that twisted space will almost certainly cause the bowel to rupture, spilling feces and barium directly into the abdominal cavity.
Which is a nightmare.
Mhm.
And the second GI pearl involves inflammatory bowel disease. Patients are often prescribed a drug called sulfasalazine.
Yeah, and the clinical insight here is understanding how the drug physically breaks down in the body. It cleaves into two parts. The 5-ASA component is the active agent that miraculously coats and heals the inflamed bowel wall.
Okay, so that's the good part.
Right, but the remaining sulfapyridine component is entirely responsible for the drug's nasty side effects.
Wow, okay. Let's take a step back and look at the bigger picture. We have established that the kidneys filter the blood, but their secondary job is actively regulating systemic blood pressure by adjusting fluid volume and vessel constriction,
Right.
which ties directly into our next system, the endocrine control centers. Hypertension is the silent killer we see everywhere, obviously. Over 95% of cases are essential hypertension, meaning there's a complex web of genetics and diet, but no single anatomical cause.
Yeah, it's the secondary hypertension that really requires clinicians to play detective.
Yeah.
A textbook example of this is renal artery stenosis, particularly a form called fibromuscular dysplasia seen in young females. The artery feeding the kidney physically narrows.
Okay, so this is where we see pharmacology and physiology collide. In a patient with renal artery stenosis, the kidney isn't getting enough blood flow.
Exactly. And to maintain enough internal pressure to actually filter urine, the kidney clamps down hard on its exit pipe, which is the efferent arteriole.
Right.
That constriction creates a back pressure, keeping the filter working.
Which is exactly why the source text screens a massive warning about prescribing ACE inhibitors to these patients.
Yes, ACE inhibitors are incredibly common blood pressure medications, but their primary mechanism is dilating that examined exit pipe, the efferent arteriole.
Oh, I see.
So if you give an ACE inhibitor to a patient who is relying on a constricted efferent arteriole just to survive, you essentially blow open the exit valve.
And the back pressure just vanishes.
Yep, the filtration rate drops to zero, and you throw the patient into acute renal failure.
That is such a huge danger of treating a number instead of the underlying plumbing. And that prolonged high pressure, it really tears apart the end organs over time, causing left ventricular hypertrophy in the heart, microscopic strokes in the brain, and severe retinopathy in the eyes.
Yeah, and the other systemic wrecking ball is diabetes mellitus. Instead of physical pressure, this is metabolic toxicity.
Right. Type I is a structural failure where the pancreas completely stops making insulin.
But type 2 is a story of resistance, heavily driven by excess adipose tissue in higher BMI categories. The body makes insulin, but the cells just refuse to listen to it, leaving toxic levels of sugar circulating in the blood.
And the pathophysiology of the diabetic foot is just the most devastating example of this system crash, because high blood sugar slowly destroys the peripheral nerves, leading to sensory neuropathy.
And at the same time, it accelerates peripheral vascular disease, destroying the blood vessels, feeding the extremities.
Right, so having neuropathy paired with vascular disease is like driving a car with a broken dashboard warning light. Your engine is literally tearing itself apart. Maybe you have a rock in your shoe creating a massive ulcer, but the nerves just don't send the warning signal.
It's tragic. You have no idea there's a problem until the engine completely stalls, the tissue becomes gangrenous, and you face an amputation.
Yeah. And the endocrine system controls multiple subtle dials, too. For instance, diabetes insipidus has nothing to do with blood sugar.
No, not at all. It involves a lack of antidiuretic hormone. Without that hormone telling the kidneys to retain water, the patient loses massive amounts of fluid, outputting 5 to 15 liters of completely colorless urine every single day.
That is so much fluid.
Or consider the thyroid gland. If severe hypothyroidism is left untreated, the entire metabolic rate slows to a crawl, culminating in a myxedema coma.
Wow.
The body temperature drops into profound hypothermia, and the respiratory drive just simply stops.
Which I guess brings us to the top of the chain. When the chemistry gets that toxic, whether from massive drops in oxygen, soaring urea levels from dead kidneys, or crashing thyroid hormones, the brain loses its highly sensitive chemical environment.
It does.
And this leads us into neurological crises and altered mental status.
Yeah, altered mental status, or AMS, is a broad presentation. The mnemonic move STUPID is a really great checklist to hunt down the chemical culprit.
What does that stand for again?
It stands for metabolic, oxygen, vascular, endocrine, seizure, trauma, uremia, psychiatric, infectious, and drugs.
That's a lot. But instead of just reading the list, it's fascinating to realize how these elements physically change neuron firing. Like if your kidneys fail and uremia builds up in the blood, those toxins cross into the brain and physically interfere with electrical signals.
Exactly. And when evaluating a patient's consciousness, the text divides the brain into two vital zones.
Right. An intact brainstem is responsible for arousal, the primitive reflex of being awake and keeping the heart beating.
Yes. Meanwhile, the highly evolved cerebral cortex is required for cognition, being aware, thinking, and understanding language.
So we assess coma patients using the Glasgow Coma Scale, looking at eye, verbal, and motor responses. But the physical exam of the pupils tells a much faster story, doesn't it?
Oh, absolutely. When a patient suffers severe anoxia, meaning the brain is completely starved of oxygen, the pupillary muscles lose all their tone. This leads to bilateral fixed and dilated pupils. The system is dead.
Right.
Pinpoint pupils, on the other hand, strongly suggest narcotic overdose or bleeding deep in the brainstem.
But the most urgent pupillary finding is a unilateral fixed and dilated pupil, just one eye.
Yes, that indicates a herniation. Swelling or bleeding inside the skull is creating so much pressure that the brain is physically being pushed downward, crushing the third cranial nerve against the base of the skull, which knocks out the pupil reflex on that side.
It's all just mechanical. And when we look at vascular strokes in the brain, the mechanism dictates the therapy. If a blood vessel bursts, causing a hemorrhagic stroke, you have to control the bleeding.
Right. But if a clot blocks a vessel in an ischemic stroke, we have options.
The classic teaching is using TPA, right? A chemical clot buster, but it has a very narrow window of just a few hours.
Yes. But the exciting shift in modern neurology is endovascular thrombectomy. Instead of just using chemicals, a surgeon threads a tiny catheter up into the brain and physically pulls the clot out of the artery.
That is wild.
And studies are proving this physical removal can save brain tissue up to 16 to 24 hours after symptoms start in specific patients.
That's incredible progress. Now, I saw a condition in the notes called subclavian steal syndrome, and I have to admit, it sounds like the title of a true crime podcast. Who is stealing from whom here, and how does moving your arm possibly cause you to exhibit stroke-like symptoms?
It's honestly one of the bizarre vascular anomalies we see. So the subclavian artery supplies blood to your arm, but right before it heads down the arm, a major vessel called the vertebral artery branches off it and goes straight up the neck to feed the brainstem.
Okay, I'm with you.
In this syndrome, there is a severe narrowing in the subclavian artery right before that branch point.
Okay, so the arm isn't getting great flow.
Right. But when you vigorously exercise that arm, the arm muscles start screaming for oxygen Because the main supply line is blocked, the vascular system takes the path of least resistance.
Wait, don't tell me.
The blood flow literally reverses. It flows backward, down the vertebral artery from the brain to feed the working arm.
That is mind-blowing. The exercising arm literally steals the blood supply directly away from the brainstem.
Exactly. It causes vertebrovascular insufficiency. The patient gets dizzy, their vision blurs, and if you take their blood pressure in that exercising arm, it will be noticeably lower than the other side.
Wow. Okay, so we've covered the organs, the pipes, and the brain. To finish the systemic loop, does this interconnectedness reach even the joints?
It absolutely does. Rheumatology often relies on joint fluid analysis to diagnose systemic issues. We look at the white blood cell count in the synovial fluid.
Okay.
A normal joint has fewer than 200 white blood cells. If you see between 5,000 and 50,000, you're looking at a systemic inflammatory response, like rheumatoid arthritis or gout crystals acting like sandpaper in the joint.
Ouch.
Yeah. But if that number skyrockets over 50,000, you have
Yeah.
septic arthritis. That's a highly destructive bacterial infection actively eating the joint space.
And that takes us full circle. As we wrap up this deep dive, the overarching lesson here is pretty clear. Medical education demands you memorize specific algorithms and cutoffs, like the FENA percentage or the classes of hemorrhage.
Right.
But the true art of clinical medicine is recognizing the biological domino effect. A failing pump drops the pressure, which starves the renal filters. The broken filters alter the body's chemistry, and that toxic chemistry eventually short-circuits the master computer in the brain.
Perfectly said. To truly practice medicine, you really have to look past the isolated symptom and understand how it ripples across the entire physiology of the patient.
Absolutely. So, to reinforce what we've unpacked today, here is your clinical review exercise. Listen carefully. A 30-year-old female patient presents to the clinic with a sudden onset of severe refractory hypertension. Upon examination, you hear a distinct rushing sound, a bruit, over her right upper abdomen. What underlying secondary condition ties these symptoms together, and what incredibly common class of blood pressure medication must you absolutely avoid prescribing to her?
Well, you are looking at secondary hypertension caused by renal artery stenosis, likely fibromuscular dysplasia. And because her kidney relies on back pressure to function, you must avoid prescribing ACE inhibitors, which would dilate her efferent arteriole and cause acute renal failure.
Thank you so much for joining us on this clinical journey today. Keep challenging your understanding of the mechanisms, keep looking for the physiological connections, and keep learning. Because the human body is never just a list of symptoms. It's an incredible, interconnected machine